Hi, I'm Shannon Delaney, Assistant Professor of Psychiatry at Columbia University Irving Medical Center. Today I'm presenting the course Neuropsychiatric Symptoms and Lyme Disease as part of Invisible International's Medical Education Initiative. This program, which includes a large library of free CMEs, is generously supported by the Monte Calvo Family Foundation. I have no conflicts of interest or disclosures to report. The outline of my talk today, I will begin by talking about post-treatment Lyme disease syndrome, or PTLDS, discuss the definition and also prominent literature pieces regarding PTLDS. I will also talk about immune biomarkers in Lyme disease and mechanisms of disease, and focus a lot on neuropsychiatric manifestations of Lyme disease, and then at the end talk about some treatment options. Lyme disease and tick-borne illness is truly an epidemic in the U.S. Lyme disease has now been reported in every state. Lyme disease is caused by the etiologic agent Borrelia burgdorferi, which is a bacteria. The CDC estimates that 476,000 Americans are diagnosed and treated for Lyme disease each year. And about 10 to 20% of those who develop an EM rash develop post-treatment Lyme disease syndrome, or PTLDS, and I'll discuss more about that in just a minute. I wanted to include this slide about erythema migrans rashes, EM rashes, because most people, including a lot of doctors, when they think of an EM rash, they only think about the classic bullseye rash. But there was one study showing that actually the classic bullseye rash only represents about 20% of the EM rashes. So these pictures just show that EM rashes can look very different. So bottom left, you can see large red oval plaque. Top right, you can see an expanding rash with a central crust. And then bottom right, you can see evidence of multiple rashes, which indicates disseminated infection. So post-treatment Lyme disease syndrome, what is it? So it refers to persistent symptoms that develop within 6 months of diagnosis and treatment. And the important piece here is that it involves functional impairment. So this term PTLDS is embraced more by the academic community, as a syndrome implies that the pathophysiology is unknown. We know from the literature that about 10 to 20% of the patients who are treated for Lyme disease at the time of the EM rash will develop PTLDS. It's a pretty staggering amount of people, considering, if you remember, that the definition involves functional impairment. So these are ideally treated patients. Will be 10 to 20% of them will be functionally impaired after a diagnosis of Lyme disease. And because PTLDS involves functional impairment, the idea of persistent symptoms without functional impairment is likely higher. One study showed that 36% of patients continue to have persistent symptoms after Lyme disease. So I really like this study from the New England Journal of Medicine. It's a bit on the older side from 1990. But it does a great job of highlighting chronic neuropsychiatric manifestations of disease. It's a relatively small study, 27 patients, all who had Lyme borreliosis, neuroborreliosis. And interestingly, if you look at table 1, they calculated the median time from EM rash to peripheral nervous system involvement, and it was 16 months. And then they calculated the median time from EM rash to chronic central nervous system involvement, and it was 26 months. So this is really a staggering figure, in my opinion, very sobering, because what it says is that months to years after the initial infection with Borrelia burgdorferi, patients may develop neuropsychiatric symptoms. So table 2 does a nice job of really outlining the clinical characteristics of these patients. So you can see that 89% of them reported encephalopathy, so some sort of confusion, mental confusion. About 37% endorsed depression. A surprisingly high number, about 70% endorsed polyneuropathy, and also fatigue and headache were significant as well. This is a little bit more of a recent patient paper from 2017. This was from Dr. John Alcott's group at Hopkins, and they were looking at PTLDS patients versus healthy controls. And I really like this table because it highlights the common clinical characteristics that we see in this PTLDS population. So you can see that they have statistically significant more fatigue, joint pain, focusing problems, muscle pain, memory problems, word finding problems, sleep problems, neck pain, and irritability compared with the control population. What I also like about this figure is if you look at the control population, you can see that light blue represents mild symptoms, medium blue represents moderate symptoms, and then the darker blue represents severe symptoms. So it wasn't as if the control population didn't report having any symptoms. They actually had a fair amount of mild symptoms. But if you compare it to the PTLDS population, you can see that they have significantly more moderate to severe level of symptoms in all of these domains. So what are the contributors to neuropsychiatric symptoms? Well, likely there are probably a lot of biological mechanisms at play. So one of the prevailing theories is persistent infection, ongoing inflammation, and also a post-infectious autoimmune component are also big theories as well as altered neurocircuitry in the brain. So psychologically, there are likely a lot of amplifiers. Our group at Columbia published a paper last year showing that prior trauma plays a role, as well as a lot of these patients with Lyme disease have significant stressors. So a lot of them are suffering from daily chronic pain. Oftentimes after they get sick, they may lose their job and have to go on disability. So a lot of economic stressors. And then after a diagnosis of Lyme disease, it can cause a lot of interpersonal strife in their family relationships as well. Universally, I hear from patients a lot that they feel invalidated by their healthcare providers. And there's also a lot of uncertainty regarding diagnostic tests and treatment options. And all of this uncertainty can generate a lot of anxiety and anger. So switching gears for a second to talk about persistent infection. What is the evidence in the literature regarding persistent infection? Well, we know that Borrelia burgdorferi can persist in the animal host, in dogs, mice, and monkeys. We also know that Borrelia that persists are living, infectious, and stimulate an ongoing immune response. However, interestingly, they're not able to be cultured. From a human standpoint, there's a case report written by Dr. Ken Ligner, who is a prominent Lyme doctor in the field who's been treating patients for a few decades. He published a unfortunate case of his patient who was a 39-year-old ICU nurse who died of complications related to Lyme disease. The CDC previously confirmed her spinal fluid to be culture positive for Borrelia burgdorferi. This was also after already receiving months of IV antibiotics. One of the most interesting studies that I think that has been done in the Lyme disease realm is the xenodiagnostic study. So in this study, they had clean ticks. So these are laboratory-raised ticks that are pathogen-free. And they placed them on a bunch of brave participants. There were 26 participants with treated Lyme disease. So there was 10 who had a positive C6 ELISA, 6 who had a previous EM rash, 10 who had post-treatment Lyme disease syndrome, and 10 healthy controls. They had multiple ticks on each participant, and they left the ticks on, I believe, for a few days. So in the end, one tick was Borrelia PCR positive, so they found evidence of the DNA of the Borrelia bacteria in one patient with PTLDS. So what are the mechanisms of persistent infection? Well, if we analyze human and animal tissues, we can find Borrelia spirochetes found to be intercalated in the collagen-rich matrices. This is evidence of immune evasion. We also know that Borrelia can modify its outer surface protein expression depending on a lot of environmental factors like pH, temperature, and other factors. It also has the ability to produce proteins that bind to and inactivate a key component of complement, which is an important part of the immune system. We also know that Borrelia can revert to a bunch of different forms. The spirochetal form is the active form, but it can also revert to round body and microcolony biofilm-like forms, and all of those other forms have varying degrees of metabolic activity. Also, we know that Borrelia persisters in the lab, so in vitro, they're not killed by standard antibiotics. So what are the Lyme Wars? The Lyme Wars refer to the conflict between patients, doctors, researchers, and insurance companies. And the conflict centers around what are the signs and symptoms needed to diagnose the disease? How accurate are the blood tests and how do you interpret them? Do some patients with persistent symptoms have persistent infection? So this is a much bigger topic than I have time to kind of delve into properly today, but I do recommend further reading if you're interested in this. My colleague, Dr. Brian Fallon, wrote an excellent book, Conquering Lyme Disease. Another deep dive phenomenal read is Cure Unknown by Pamela Weintraub. She is a scientific investigative journalist who wrote about her own family's experiences with Lyme disease. And if you want something a little bit more digestible, although New Yorker articles are still quite long, I would recommend The Lyme Wars from the 2013 issue. So this is a cartoon where the doctor is telling the patient, the bad news is you have Lyme disease. The good news is I don't believe in that disease, so you're fine. So this is an attempt to inject humor into a pretty serious topic. But in reality, we know that patients can often feel invalidated by their medical professionals, and this invalidation can be quite traumatic. So switching gears a second to talk about biological correlates of PTLDS, there have been multiple studies showing immune biomarkers associated with PTLDS. So in 2010, a very interesting study was published showing that anti-neuronal antibodies were elevated in the Lyme disease group at a level equal to those with lupus, and I'll tell you more about that study in just a minute. 2014, it was shown that in patients with Lyme arthritis, endothelial cell growth factor antibody was elevated in those patients. There have been numerous studies showing evidence of inflammation in this population of patients, including elevations in IL-6, interferon alpha, and the chemokine CCL19. A more recent study in 2019 showed that the Borrelia peptidoglycans are just part of the cell membrane, composed of both sugars and amino acids. They were found in the synovial fluid in patients with Lyme arthritis. Also, an earlier study from 2011, Dr. Schutzer showed he looked at the spinal fluid of patients with Lyme disease, and he compared them to two other groups, those who have chronic fatigue syndrome and healthy controls. And they found that the Lyme disease group had proteins that were unique to Lyme disease that distinguished from the control group and the chronic fatigue group. So this is the study showing the anti-neuronal antibodies that are elevated. You can see that there were 4 groups of participants. One is a post-treatment Lyme group, one is a post-Lyme healthy group, a normal healthy control group, and then SLE represents the lupus group. So you can see that the post-Lyme group and the lupus group have similar amounts of anti-neuronal antibodies present in their serum. And then off to the right, you can see 2 patients' sera that reacts to brain tissue. So the outstanding question is, when should you suspect that neuropsychiatric symptoms might be related to Lyme disease? So certainly if you see a patient who's presenting with multi-system symptoms that emerge after a known viral-like illness, so especially a summer flu-type presentation, think Lyme disease, but also if the patient that you're seeing has certain exposure to a Lyme endemic area, and if you're in the Northeast where we're at, pretty much the entire environment is a Lyme endemic area. However, you should think about Lyme disease even more seriously if you have a patient that loves to garden, has a house in the woods, is an avid golfer, things like that. From a laboratory finding perspective, you should think about seroconversion. So early on in the disease, often you only see IgM antibodies. But a few weeks later, if you see the production of IgG antibodies, that's evidence of seroconversion. And certainly if you're checking serial titers and you see an increase in antibody titers, that should also make you suspicious. And if you do a lumbar puncture and you see that the spinal fluid is abnormal, but especially if it has Borrelia antibodies, that is pathognomonic. So when you encounter just a psychiatric disorder, when should you think about Lyme disease? Well, you should especially think about it if the presentation is atypical. So if the patient is manifesting symptoms of psychiatric problems at an odd age, most psychiatric problems are first diagnosed in late teens or 20s. So if you see a patient with a new onset psychiatric problem in their 40s, 50s, 60s, that should raise the alarm bell. Also, if you see a young child, like a 7-year-old who was just diagnosed with schizophrenia, that is very, very rare. So that should make you think that maybe there's an organic process going on. Also, if you encounter a patient that has a lot of cognitive features, so if you see a patient that gets neuropsychological testing done and there's problems with their verbal fluency, so this can manifest as word finding problems or significant memory problems, that's definitely classic for what we see with neuroborreliosis. If you see a patient with a lack of personal or family history of psychiatric disorders, you should think about something organic as well. And then lastly, oftentimes patients come to us and they've been down the psychiatric road. They've tried numerous different psychiatric medications and none of them have been helpful. In fact, sometimes a lot of them have been hurtful. So if you see a patient who's not responding at all to numerous different psychiatric medications, also from different classes of medication, think that there might be something else contributing to that presentation. So these are two cases of Lyme encephalitis that can present with severe psychiatric disorders. The first case is a 55-year-old woman who presents with new onset manic psychosis. So right there, before we even delve into the details further, it's very unusual for a 55-year-old woman to develop new onset manic psychosis at that age. So in this particular woman, her mania was the initial symptom, and then days later, she had more physical type symptoms of radicular pain and weakness. Her lumbar puncture ended up not being positive for Lyme antibodies until 8 weeks after the first onset of her symptoms. Interestingly, her mania, her radicular pain, and her weakness resolved with appropriate antibiotic treatment. And the second case is also an example of an older person outside of the teens, 20s range. This is a 42-year-old woman. She's presenting with new onset schizophrenia-like disorder, so that should ring some bells as well. This was a patient who had cognitive problems initially and irritability, and this was followed by paranoia and hallucinations for 8 months. Finally, after they did a lumbar puncture on her, neuroborreliosis was diagnosed. So this patient had no systemic physical signs or symptoms suggestive of Lyme borreliosis that were present. She had only psychiatric symptoms, but she had a full recovery after antibiotic treatment. So this case is called Bicycle Boy. It's probably one of my favorite cases. And to my knowledge, it is the first Lyme PANS case that has been written about in the literature. This goes back to the early 80s. This is when the Borrelia spirochete was first being discovered, actually. This was a 12-year-old boy who had Lyme arthritis in one of his knees, and he was put on doxycycline for a month. His Lyme arthritis improved, and then out of the blue, 2 months later, he became very withdrawn and depressed. He wasn't interacting with his friends. He wasn't going to school anymore. He stopped eating and was exercising compulsively. They diagnosed him with anorexia, And because during this time, this was the early days of Lyme disease, there was a lot of energy and enthusiasm for Lyme disease. And because he had a prior history of Lyme disease, he was transferred to Yale, where they did a lumbar puncture on him and found his spinal fluid antibody titers to Borrelia were elevated. But interestingly, his neurological evaluation was normal. So he was treated for 2 weeks with IV penicillin, and he gradually improved and went back to his normal baseline. This was a study that was done in an academic Lyme disease referral center, and they looked at, I believe, about 159 patients as part of their center, and there were 4 different groups of participants. The first group, represented in blue, was a definite history of Lyme disease presenting with PTLDS symptoms. The second group, represented in green, was self-reported history of Lyme disease. So they had no laboratory evidence indicating a history of Lyme disease, but they thought they had Lyme disease. They were also presenting with medically unexplained symptoms. The third group is represented in orange. This was a Lyme disease recovered group. And the fourth group was a medical control group. So this was a group who had chronic symptoms that were attributed to different medical conditions. So as you can see, they looked at depression, dysthymia, anxiety, and access to disorders. And you can see that depression was 4 times more frequent in the patients who had a definite history of Lyme disease compared to the other populations. I should say that there have been other studies that have not found an increased risk of depression. These were longer-term follow-up studies, anywhere from 6 months to 20 years follow-up, and all 4 of these studies did not show an increased risk of depression. So certainly there's some question marks about where the real truth lies in this situation. There were some limitations in some of the studies. Some of them have definitely a small sample size. They had unclear diagnostic criteria sometimes, and there was a fair amount of ascertainment bias. So some of the patients came from psychiatric practices or research clinics, and some of the studies did not have an appropriate control group. Unfortunately, suicidal ideation is quite common in patients with persistent symptoms related to Lyme disease. This study was done out of our center, our Lyme Center at Columbia. It involves 81 adults with well-documented treated Lyme disease who are now presenting with persistent cognitive symptoms, again, evaluated at our center at Columbia. 1 in 5 of these patients, so 20%, reported having suicidal thoughts. And of the group that had greater than mild depression, so moderate or severe depression, 63% of them had suicidal ideation, which is surprisingly very high. And we could even say that our sample could be biased against suicidal ideation, as these patients actually were clearly not helpless or hopeless because they were coming to our research center to obtain treatment. And this frequency is actually comparable to what we see in research patients with HIV at our site as well. So we really did need a larger study, a more epidemiologically oriented study to address some of the limitations of the prior studies. So this was a nationwide cohort study in Denmark done of the entire population over a 22-year period. The question at the outset of the study was, is Lyme borreliosis in all of its manifestations associated with a higher rate of mental disorders, affective disorders, suicide attempts, and suicide? So there were almost 7 million people who were part of the study, and you can see the number with Lyme disease was over 12,000. So in order to be characterized as having Lyme disease for this particular study, they had to also not have a prior mental health diagnosis. And Lyme disease in the study was diagnosed in the outpatient world, inpatient, or ER setting. So is a hospital-based diagnosis of Lyme disease associated with a subsequently increased risk of mental disorders? The answer is yes across the board. You can see that if you have a history of Lyme disease, you have a 30% increased risk of any psychiatric diagnosis. You have a 40% increased risk of affective disorder, a twofold increased risk for a suicide attempt, and a 75% increased risk for completed suicide. So again, the rate of suicide after Lyme borreliosis was increased by 75%. The rate of suicide was even higher. It was 2 to 3 times higher if you've had more than one episode of Lyme borreliosis, or if there was a temporal proximity. So if it was less than 3 years since the initial diagnosis of Lyme disease. So are these results surprising? I would say no. And the reason for that is that we have had a lot of prior nationwide studies demonstrating that serious infections are associated with increased rate of mental disorders and also suicide. Many infections have been associated with neuropsych disorders, including HIV, EBV, now COVID-19, strep infection causing pandas, Toxoplasma gondii as well. We also know that peripheral inflammation is known to lead to depression. I did want you to know about a very important screening tool. This is called the Columbia Suicide Severity Rating Scale, the CSSRS. If you go to the App Store, you can find it by putting in Columbia Protocol. It's a free app, and it's a very convenient, very straightforward way to assess suicidality. As you can see, it's very short. It's only 6 questions. And at the end, it categorizes the patient as either being low risk, moderate risk, or high risk. So this was a PET study that was done with 37 patients with PTLDS. These patients were extremely well-characterized patients with Lyme disease that previously had had significant treatment with both oral antibiotics and IV antibiotics. And this was compared to 18 healthy matched controls. So in this PET study, they did a carbon dioxide challenge. And what they found was the participants in the Lyme group showed decreased regional metabolism and a diminished ability to enhance blood flow compared to the healthy controls. So this was clearly an example of showing an objective neurobiological deficit in the patients with PTLDS compared to controls. Of course, it doesn't tell us exactly what is causing this deficit. It doesn't prove that it's persistent infection or a post-infectious problem, but it does show objective neurobiological changes. Another PET study was done looking at microglia. So microglia are the resident immune cells in the brain, and this study was done more recently in 2018. They looked at TSPO, which stands for translocator protein, and the binding of TSPO basically indicates microglial activation. And it was a relatively small study looking at only 12 patients with PTLDS who had different durations of symptoms. Some of them had symptoms for 6 months or longer and fit the PTLDS diagnosis. Others had symptoms for less than 6 months. But the overall verdict of this study was that in the Lyme group, compared to the 19 healthy control group, the microglia were found to be activated. So this is another example, objective example, showing neuroinflammation in the PTLDS group. Neuropsychiatric and other persistent symptoms. What are the potential causes that guide treatment choices? Again, this is going back to the concept that I introduced before. Many people think that there is persistent Borrelia infection, or at least remnants of the infection. Others believe that it's more of an immune dysregulation. Neural network dysregulation is likely also playing a role, and then potentially other unrecognized infections or causes. What are some therapeutic approaches? So certainly targeting persistent infection. Oftentimes these patients are treated with repeated antibiotic treatment. Sometimes patients will say their symptoms significantly improve on antibiotic treatment, and once they stop antibiotics, some of the symptoms will relapse. Oftentimes, doctors will also treat with IVIG. So this is targeting immune dysregulation. IVIG can be especially helpful in people who also have comorbid autoimmune conditions or have neuropathies. Psychiatric medications target the neurotransmitter systems. So psychiatric medications work on things like glutamate, GABA, serotonin, norepinephrine. And more of a futuristic goal is targeting altered microbiome. We know that if you alter the microbiome, it's also capable of altering neurotransmitter systems in the brain, which is pretty amazing. Encouraging patients to adopt stress reduction programs is helpful. Things like meditation and yoga will help increase the parasympathetic nervous system, which will help the body rest and digest. And psychotherapy plays a big role. So a lot of these patients, it's helpful to learn coping skills training. Some of them just need plain old supportive psychotherapy because they don't have a lot of people in their life to help support them. And then cognitive behavioral therapy is frequently used as well. From a rehab perspective, both cognitive rehab and physical rehab can be sometimes helpful. And neuromodulation is sort of a wave of the future. We actually soon will be starting 2 different research studies on patients with Lyme disease. One is involving transcranial direct current stimulation, and the other is involving vagus nerve stimulation. So that's very exciting. Different pharmacological approaches to these patients. Many of them do suffer from severe fatigue. So I frequently use bupropion, which is an antidepressant that can also help with fatigue and also help with attention problems. Modafinil or stimulants may be used as well. A lot of the patients who've had neuroborreliosis can have ongoing issues with light or sound sensitivity. So things like gabapentin, carbamazepine, and clonazepam can sometimes help with that. For mood dysregulation, my favorite medication is lamotrigine. I use a lot of it in both adults and kids. Sometimes in kids, you need much lower doses, and they can still be quite effective. It can be helpful for mood dysregulation, depression, and also suicidal ideation. I don't use atypical neuroleptics quite as often, but sometimes they do play a role, especially if someone's presenting with psychotic type symptoms. And then in terms of depression and anxiety, the standard first-line treatments are still SSRI medications that act on the serotonin system. However, I would say that I sometimes use these medications sparingly because I have noticed in this population that sometimes SSRI medications can be overactivating. So I still use them, but if I do start them, I typically start them at a lower than normal starting dose, and I use very cautiously. I increase the dose very cautiously. I do have a lot of success with bupropion. That really helps with depression and, like I mentioned before, both fatigue and attention as well. A lot of these patients have central pain problems or neuropathies. So SNRIs can be quite helpful, as well as pregabalin or gabapentin. A lot of the doctors in the community also use low-dose naltrexone to help with inflammation, to help with pain and insomnia and fatigue. So some clinical recommendations. Consider tick-borne illness workup for psychiatric conditions in Lyme endemic areas, especially if the presentation is presenting in an atypical psychiatric fashion. It's important to monitor patients for mental health sequelae from Lyme disease, especially during the first year of illness, or if you have patients that are suffering from chronic symptoms. Consider incorporating a mental health screening tool into your practice. The PHQ-9 for depression is very easy to use and straightforward, only 9 questions. And like I showed you before, the CSSRS is really a good tool for suicidal ideation. If a patient is suffering from psychiatric problems, it's important to refer to a mental health clinician. And the suicide prevention lifeline number is 988. So in summary, patients with Lyme disease often have mood, cognitive problems, suicidal thoughts, and sensory arousal problems. It's important to screen for depression and suicidal thoughts. And the course of neuropsychiatric symptoms can often occur early, but they can sometimes occur late in the infection. Most individuals do show marked improvement or recovery, but sometimes this takes a lot of time. There are probably multiple mechanisms at play that are potentially interacting with each other. So you do really need to have a focused treatment plan with focus on the most burdensome symptoms. And it's important for patients not to avoid standard mental health treatment, as these treatments can enhance brain function and recovery. And there are a lot of new treatment approaches that offer hope for the future. Thank you.